Hello and welcome. If you're gearing up for the NCLEX or just want to get your wound care skills razor sharp for clinicals, you are in exactly the right place. Today, we're going to break down everything you need to know about managing wounds and pressure injuries. My goal is to take this really complex topic and make it super clear so you feel confident on your exam and at the bedside. All right, let's get into it.
So here's our game plan. We'll kick things off with the absolute basics, how the body actually heals. Then we'll jump into assessment, what to do about it, and what to watch out for. We've got a whole section dedicated just to pressure injuries. And then we'll wrap it all up with some high-yield NCLEX tips and a case study to put your brain to the test. Let's do this.
All right, first things first. Before we can even think about treating a wound, we've got to understand the amazing, natural process our body goes through to fix itself. Seriously, this foundation is the key to everything else we're about to cover. Okay, let's get this straight right from the get-go. We throw these words around, but they are not the same thing. A wound is just a general term for any break in the skin, but a pressure injury, that's super specific. It's damage caused by pressure that's been there too long, usually over a bony spot like a heel or the sacrum. So think of it this way. All pressure injuries are wounds, but not all wounds are pressure injuries. That distinction is key.
You know, the body's healing process is kind of like the three-act play. Act 1 is the inflammatory stage. This is all about damage control. The body rushes to stop the bleeding and sends in the cleanup crew, the white blood cells. Act 2, the proliferative stage, is the rebuilding phase. This is where the body starts laying down new tissue and collagen. And finally, Act 3 is the maturation stage. This can take a year or more. It's all about remodeling and strengthening that new tissue into a solid scar.
And check this out. Wounds don't all close the same way. Primary intention is the best-case scenario. Think of a clean surgical cut, where the edges are stitched together perfectly. It's fast, and the risk of infection is low. Secondary intention is what happens when you have tissue loss, like with a pressure injury. The wound has to heal from the bottom up, which takes a long time and has a much higher infection risk. And tertiary? Well, that's when a wound is left open on purpose, maybe to clear out an infection before it's closed up later. It's the longest and riskiest of them all.
Okay, so now that we've got the basics of healing down, let's talk about assessment. This is where we learn to read the wound and figure out all the things that could be slowing that healing process down.
You know, a wound doesn't heal in a bubble. The patient's whole body is involved. Things like their age, chronic diseases like diabetes, they play a huge role. And nutrition. If your patient isn't getting enough protein, you're robbing the body of the very building blocks it needs to repair itself. Smoking is a huge one too. It messes with oxygen delivery. Even something like a bad cough can literally pull a wound apart. As the nurse, you have to look at the whole person, not just the hole in the person.
Now, to make assessment a little easier, there's a fantastic memory tool called the RYB Wound Code. Let's start with R for red. When you look into a wound and see that beefy, red, bumpy tissue, that's a good thing. That's healthy granulation tissue growing. So what's your job? Simple. Protect it. Cover it up and let the body do its amazing work.
Next in our code is Y for yellow. Now, if you see yellow, you should be thinking, uh-oh, cleanup needed. This could be slough, which is the stringy gunk, or it could be purulent drainage, which hints at infection. A yellow wound is a dirty wound. So your action is clear. You need to clean it. We have to get that stuff out of the way so the healthy tissue can grow.
And finally, B for black. Black in a wound is bad news. It means eschar, which is thick, leathery, dead tissue. Nothing is going to heal underneath this stuff. It's a huge roadblock and a perfect home for bacteria. So the action here is to debride. That dead tissue has got to go. So remember, red, cover, yellow, clean, black, debris. It's that simple.
All right, let's talk about what's coming out of the wound because the drainage tells a story. Serous fluid is that clear, watery stuff you see in a blister. Sanguineous is just a fancy word for bloody. And serosanguineous, which you see all the time after surgery, is a mix of the two, kind of pale and pink. But the one that should make your nurse senses tingle is purulent. It's thick, it's opaque, it often stinks, and if you see that, especially if it's got a green tint, you need to be thinking infection.
Okay, so we've assessed the wound, we know its color, we've checked out the drainage, now what are we going to do about it? This section is all about the hands-on actions we take based on what we found.
Wound irrigation is a bread-and-butter nursing skill, but the details really matter. You want to use a 30 to 60 milliliter syringe with a 19-gauge needle. Why so specific? because that combo gives you the perfect amount of pressure, about 8 psi, to clean the wound effectively without damaging the new tissue. You'll hold the tip about an inch above the wound and just flush with something like normal saline until the water runs clear. It's all about washing away all that debris and bacteria.
Okay, we have to switch gears for a second and talk about the scary stuff. These are the moments when things go really, really wrong. Recognizing these complications quickly and knowing exactly what to do can literally be the difference between life and death.
Let's be crystal clear here, because you have to know the difference. Dehiscence is when a wound splits open. That's a serious problem, for sure. But evisceration, that is a whole other level. That's when the wound splits open and internal organs start coming out. This isn't just a problem, it's a 5-alarm fire surgical emergency.
So if you ever walk in and see an evisceration, this is your immediate playbook. Memorize it. 1. Call for help. Scream it if you have to. 2. You do not leave that patient's side, ever. 3. You need to cover those organs with sterile dressings soaked in sterile saline. This keeps them from drying out. And 4. Get the patient on their back with their knees bent. That's going to take some of the pressure off that abdominal wall. This is a classic NCLEX question.
So how do you spot an infection brewing? Well, you look for clues. At the wound itself, you're looking for that purulent drainage, more pain, more redness, more swelling. But you also have to look at the whole body. Does the patient have a fever, the chills, is their heart rate up? And of course, you'll look at the labs for that high white blood cell count.
All right, let's zoom in on a huge topic in nursing: pressure injuries. Preventing these is one of our most important jobs, and if they do happen, you've got to be an expert at staging them correctly.
This table is your best friend for studying. A stage 1 is just redness that doesn't go away when you press on it. Stage 2 looks like a blister that's popped open. You can see the dermis. With a stage 3, you're down into the fatty tissue. And stage 4, you're down to the hardware. You can see muscle, bone, or tendon. Oh, and if the wound bed is covered in gunk so you can't see the bottom, it's unstageable. You can't stage what you can't see. Honestly, the best way to treat a pressure injury is to never let one happen in the first place. And prevention is all about these key steps. Turning your patient is king. Every 2 hours in bed, every 1 hour in a chair. You also want to keep the head of the bed low to stop them from sliding down, which causes shearing. And look at that last one, because it's a big one. Do not massage bony spots. You can actually cause more damage.
Okay, deep breath. We have covered a ton of ground. We've talked pathology, assessment, and interventions. Now, it's time to put it all together and think like you will on the NCLEX and out on the floor.
Here are the absolute must-knows for your exam. These are your memory anchors. Burn them into your brain. Know the RYB code. For evisceration, remember the 3 S's: stay, saline, supine. For prevention, know the numbers. Reposition every 2 hours, head of bed below 30 degrees. And for nutrition, that low albumin level, anything under 3.5 is a major red flag for risk.
All right, time for a next-gen style case study. Put yourself in this situation. You've got a patient. They're 24 hours out from a big abdominal surgery. They give a really hard cough, and then they grab their stomach and say, I felt something pop. Something just gave way in my incision. Your internal alarm bells should be going off like crazy.
So you lift up their gown to take a look, and your worst fear comes true. The incision is wide open, and you can see organs protruding. It's an evisceration. So, based on everything we've just talked about, what is the very first, most critical, immediate action that you are going to take? What's your next move? I'll let you think about that.